We're going to position for lumbar spine and lumbosacral spine, AP, lateral, and L5, S1 joint spaces. So for the lumbar, we are going to start with a 14 by 17 image receptor, or whatever you have available at clinical. We're also going to use a 40 SID, but 48 is recommended. If you can't get 48, you can use 48. Your patient is going to be recumbent, and shoulders, hips are going to be aligned, flat, not rotated on the table. We're also going to ask the patient to flex their knees and keep them flexed during this position. This reduces the lordosis of the spine, brings it closer to the IR. I'm going to use a shield to only shield the femurs of the patient. Make sure there are no artifacts in the area of interest, and that the patient, if it's a female of childbearing age, that they're not pregnant. For collimation, I'm going to use 8 by 14 if I'm doing a lumbar. So right now I'm going to do 8 by 14. And then for a lumbar spine, I'm going to center 1.5 inches above the iliac crest and at the mid-sagittal plane. At this point, you can bring your shield as high as you can, just away from the collimated field, and then I will ask the patient to flex her knees or his knees. Again, to reduce the lordosis of the lumbar spine. And then I would ask the patient to bring their arms on top of their chest so that the forearms are not anywhere near the radiation field. I just want to adjust my centering. Again, to the mid-sagittal plane and 1.5 inches above the iliac crest. All right, I'm ready to take my exposure. I'm going to ask the patient to take a deep breath in, blow it all the way out, and hold their breath. And then she can breathe. If I were to be doing lumbosacral spine, I would increase my collimation to 17 lengthwise. So I would have to move my shield down, maintaining those knees flexed. Best that they can. I'm still going to have 8 inches across. And I want to make sure that on my film I see the psoas muscles on this. Look for the iliac crest, mid-sagittal plane. And then again, I will give my patient the instructions to take a breath in, blow it all the way out, and hold their breath. And then they can breathe. Then I will go ahead and move over to my lateral projections. You can do a right or left lateral. It's easier for the technologist to ask the patient to go on their left side because it's easier for positioning purposes. So I'm going to ask the patient to turn on their side or assist the patient if they couldn't do it on their own. Again, double up their pillow for comfort. I'm going to have the patient flex their knees forward. And for comfort and to hold the patient's position, you also want to put a sponge between the patient's knees. Shield the femurs and put a radiolucent sponge under the patient's lower thorax to ensure that the spine is in a horizontal plane to the IR. Bring the patient's arms forward in front. That also holds the patient in position. And then I would use a 40 SID, 48 also is recommended. I would find the patient's mid-coronal plane, ensure that they are in a true lateral. And if I am doing lumbosacral, I would keep my central ray at the level of the iliac crest, and my collimation would be 8/17. I also have a lead shield behind the patient on the outside of the collimated field. What this does is it helps catch the scatter, and it gives you a crisper, sharper image. So you can always put one of these or a lap shield behind the patient. Don't forget to mark your film. And this is a left. And then I'm going to ask the patient to take a breath in, blow it all the way out, and hold their breath. And they can breathe. If I am only doing the lumbar, I would move my central ray from the iliac crest to 1.5 inches above the iliac crest, still at the mid-coronal plane. I still have my patient in a true lateral. I'm just gonna adjust my collimation to 8/14. I have my marker, I have my lead shield behind. I can also move my lap shield a little bit higher. And then I'm going to give my patient instructions. Take a deep breath in, blow it all the way out. Hold your breath. You can breathe. The last position I would want to do is going to be the L5-S1 spot film. For that, I'm going to use a 10/12 image receptor, but I'm also using a collimation of 6/8. It's quite small, but you don't need more than that. It's only that space between, the disc space between L5 and S1. As long as I have a radiolucent sponge under the patient's lower back and the spine is horizontal, I don't need to angle. I'm going to use a perpendicular beam. Then I will center my beam, my central ray, by locating the ASIS anteriorly and going 2 inches posterior from the ASIS. I'm also going to find the top of my iliac crest and go 2 inches, iliac crest 1.5 inches below the iliac crest. 2 inches posterior from the ASIS 1.5 inches distal from the iliac crest. Again, I have my lead behind the patient. My patient is shielded. Make sure they're in a true lateral position. Their knees are bent. There's a sponge between their knees for comfort. And as long as I have this sponge under the patient, I don't have to angle my X-ray tube. I can use a perpendicular beam. For this projection, all I need to ask the patient to do is hold their breath, and they can breathe. Now, if I did not have, by the way, this is recommended for all of these lateral positions, but if you did not have a sponge under the patient's lower thorax, what you need to do is angle your beam to line up to the iliac crest and angulation. So you find the top of the iliac crest, and if there's an angle, whether it's cephalic or caudal, that's how you would adjust your central ray. This line will be lined up to the tops of the iliac crest. And you will still enter 2 inches posterior from the ASIS and 1.5 inches distal from the iliac crest. That's it for lumbar spine and lumbosacral.